Thanks for joining. So myself and Dr. Lester Russell, we're going to be talking about how COVID-19 has affected the health technology market. We've obviously seen a lot of health technology companies, posting and saying they've had a huge amount of work come onto them. So just talking about different areas of how they're supporting the NHS, and also how this can affect them long term as well, post-COVID. So yeah, I think to open up, if we just, if Lester, if you want to give you a bit of background about yourself,
Sure.
So open things.
Yeah. Well, thanks for the invitation to take part in this. I trained as a medic and worked in hospital for several years before going into general practice. And I was a full-time GP for 11 years in total. And during that time, developed an interest in IT and in what we now call digital health. And I did an MBA and decided to leave my practice and dive straight into digital health alongside maintaining practicing on a part-time basis. So I've been working in digital health for 20 years now. And initially I started a company called egp.com, which was in the .com era. And that was around doing virtual consultations, not in real time because we didn't have the technology then. But and then I moved to Fujitsu, worked on the national program, then to Intel, where I led an innovation team, and most recently been working at IBM in their Power AI division there. And so that's me.
Fantastic. So yeah, definitely the chat that we want to talk to about this subject. So great. And just a really brief background to Prisma, just to give you a bit of an idea of why we're talking about this subject. So Prisma as a business, we're a talent solutions provider. So we help providing people function advisory and support to high growth companies. So we help them scale successfully. And where this kind of sits with the conversation that we're having today is myself and my business partner, Dan Byrne. We've always had a really keen interest in the digital health market. So we do work cross industry. With the digital health market, we started to get involved with about 4 or 5 years ago now. And Dan and myself have known Lester for a couple of those years. And we just find it a really fascinating market, how it's shaping the health industry and the advancements it's bringing to the NHS and the wider community globally. So this really got me thinking, with COVID, how much of the almost, I guess, forced adoption of technology in the NHS, how much of that is going to stick once we go back to normal, and how and also how has that accelerated digital into the NHS, where a lot of digital health tech providers have said how before COVID, the main challenge in launching is getting their technology into the NHS through the procurement channels and getting clinicians to use it. So we thought we'd jump on with Lester and have a discussion around these topics. So I think just to open up the conversation, Lester, if I can just ask just your, I guess, general opinion on how technology firstly has helped the NHS during the COVID crisis.
Yeah, and I think it's important to say that the NHS and health practice in general has lagged behind the consumer experience consistently over the years, and I think the use of IT in healthcare is lagging. Probably not much more than in other industries, although you could use financial services as a good example of where IT is used very extensively. And from a consumer point of view, we are used to logging onto our banking and so on. But if you contrast that with the health situation, then we weren't used to using technology. But what's happened with this crisis, and people have found that they just cannot safely have face-to-face interactions. So they've used the technology and it's just pushed it along. And there's a question there about why did it take that crisis to do that? What was holding things back? And some of it was just around, well, that's the way we do things around here, just that kind of inertia and that viscosity, that resistance to change that we're all familiar with. Some of it around concerns with security, confidentiality, data passing back and forth, and those kind of things. But zooming out from all of that, if you look at how technology is deployed, technology is one part of the puzzle. It's people, process, and technology. And technology is usually not the constraining factor. It's usually around the people and the processes and those sort of soft things. So as the saying goes, the really, really hard stuff is the soft stuff. It's getting people to change what they do. And I think what this crisis has done for us is give a massive shove so that people have had to change and had to use the technology, which has been sitting out there for some time, but they've had to use it. And not just health, you know, we're seeing in as we see on the news and in our daily interactions every day, people are using different video conferencing platforms. We've had FaceTime on our phone and other ways of doing that for some time, but to use it, as it were, professionally and sit in front of your computer and have meetings, we've done a little bit of that. I've worked in a global role and where we've had to do that because of being literally on different continents and certainly in different countries. But this has really pushed things forward. So it's given us a tremendous boost, and I don't think it'll snap back to exactly where it was.
A couple of statistics that I picked out from online, such as, so the NHS, they were able to pick 11 suppliers for video primary care consultations after a 48-hour tender. I think that's absolutely, I mean, that's so fast, you know, not just for any company going through a tender process, but the company, the beast of the NHS, with how notorious it is, and to get technology into it, it shows that, well, I mean, it had to be this kind of crisis, but, you know, it can be done. And I read on online, on an online journal, how doctors were amazed at how quickly telemedicine can be implemented with efficiency. So do you think it could be the case that before COVID and before technology was having to be used, some clinicians just maybe were just behind the times themselves in terms of understanding, you know, how much technology had developed and how easily it could, you know, firstly make their jobs, but also easily be implemented?
I think that's certainly a factor and a big factor. You know, on the other hand, in the surgery, in the consulting room and so on, there are daily frustrations with the technology, which have probably been eased a little bit with pushing things forward. And another big factor is the regulatory environment and the concerns about information governance and security and confidentiality, all of which are really, really important. And this is not to argue against regulation, because it's very important, and it's important that the regulators continue to do what they do. But it is when we go back to, or we move gently maybe towards, you know, a more normal way of working, I think we have to be really careful that we don't just go back to what we were doing before, and we don't over-regulate. Regulation, it's a little bit like screening, where people tend to think that it's a universal good and no harm ever comes. And that's just not the case. I mean, if you take screening as an example, you know, it's a truism that all screening does harm, which sounds like an extreme thing to say, but what it means is there are costs and benefits to screening. You're going to have false negatives, you're going to have false positives, there's a financial cost, there's a cost of worry, and so on and so forth. And so it is with regulation and rules. They have costs because they do constrain innovation. They also constrain maverick activities, which is a good thing. So we have to be, as I said, this is not an argument against regulation, but we just have to be measured and careful and thoughtful with how much regulation we relayer over the system when we move back towards normality.
If you look at, you know, going forward, if, you know, technology is continually implemented and used by the NHS, around kind of regulations around patient data, you know, it's increasingly easy now for patients to access their own medical records. I mean, I know there's a number of apps where you can, you know, get all your tests booked and everything done, and access your medical records. Do you think there'll be maybe, obviously the NHS keeps patient confidentiality and is very strict on the data and how it's used, but with so many third-party providers coming into NHS and private organisations, you know, using data for different purposes, for research, for applications, you know, do you think there could be a sense of maybe the public maybe not knowing fully how their data is handled, you know, issues with that, and the NHS being so reliant on, you know, technology companies that aren't part of the NHS?
Yeah, it's certainly an important consideration. People do make the assumption that when we share information with other clinicians or with other parts of the NHS or outside the NHS, of the private providers, then that information is secure, that it's
Mm.
only shared for the purposes of providing clinical care to them, and that it will benefit them, and it won't be exploited by commercial organizations, etc., etc. So it's really important that those assurance that we live up to those tacit assumptions that patients and individuals have. And we've seen, all of the sort of debacle around social media and the use of data and Cambridge Analytica and so on, without people understanding exactly what is going on with their data. I'm working with a company at the moment which has got a really interesting proposition, because it enables people to download all of their data from all of the different health outlets, health providers, so they have control of it. So it's not sitting with some third party who can mine it for profit. It's sitting with them, and they can see that they can, if they want to, they can give anonymous access to researchers who maybe want to contact people with their particular illnesses and if they want to take part in trials. But fundamentally, they are in control, and it's sitting on their computer or on their private cloud. So I think that kind of solution will come to the fore. And now that we've seen what's possible, then, as I said, when we get back towards normality, maybe we won't rein it in and lock it down completely as it was before. Maybe we'll be a little bit more liberal with the oversight, with the sensibility wrapped around it. But then we'll get more utility from it. We'll get more usage from it.
Yeah, no, definitely. Yeah, and hopefully as well, people can see, both the public and clinicians, people who work in the NHS, can see how much benefit the technology space has on health. So pre-COVID, just from an investment perspective, 1.7 billion was invested in the UK health tech scene in 2019. So there's a huge amount going into it, and looking at the numbers of health technology companies that are popping up, you've got so many companies specializing in really interesting, exciting areas, but in very, very specialist niche fields. And one question that kind of popped into my head was, for example, my earlier point about 11 suppliers for video primary care consultations, 11 in an organization. Do you think there could be an element going forward, if the health tech scene continues to really explode and grow, that there almost is too many niche small providers, and there could be multiple trusts with multiple different systems, video systems, and the whole point of collaboration and kind of help the NHS align on costs would almost need, digital health company to take kind of almost like a look of, let's all collaborate, let's combine our forces and provide key streams of patient software management and video consultations and all the different areas that you have. That also applying to the pharma space, the drug discovery companies using machine learning and AI. What do you think about kind of that point and the possibility?
Yeah, it's a very good point. And I think there's a spectrum there, where at the one end you've got one system being mandated centrally, which we know from the national program just won't work, and that constrains innovation, it constrains competition, and it imposes a solution that people will resist very strongly. At the other end, you've got complete competition with let 1,000 flowers bloom and no standards, and as you say, people doing very different things at a very low level, at a very granular level, and then the interoperability becomes a problem, the connectivity becomes a problem, and that's where most of the benefit is in health data, that connection between those different sources of data. So in the middle, there's something which I would reflect on, how general practice became digitized. If you look at the 90s, there was a fair amount of resistance to using computers in general practice and moving off those little cards, the Lloyd George notes and so on. And I witnessed that. But what happened was there was something called Rules for Accreditation, or RFA, and basically what that was a set of standards, a set of minimum requirements that was mandated. But within those minimum requirements, then the reimbursement would work for the practice that chose to adopt a system that fitted within those requirements. But a specific system was not mandated. And that led to fairly healthy competition between GP IT providers, and it led to the digitization of general practice, coupled with the pressure to move into the digital world, which came from the QOF, or the Quality Outcomes Framework, where GP practices are small businesses, so they want to maximize their profit, obviously, and maximize their efficiency. And the quality outcomes framework, it made it necessary to be computerized. Really, you couldn't run it at maximum efficiency if you were still on paper. So those two things together led to probably one of the best computerized areas, certainly of the NHS, and compared then very favorably globally. Obviously, things have caught up now. Although if you look at the hospital space, it's still not as well computerized, not as well digitized as general practice.
Mm-hmm. And so with that, so the hospital space, like another point that I know we've spoken about previously is looking at, again, pre-COVID, there was so many articles in the news about how much of a strain the NHS was under, patient wait times and beds and not enough beds being, available, and just the whole process of it. Do you think, post-COVID, with how much technology is coming in, it's going to actually have a really good impact on kind of the health economics aspect of, cost savings and helping the NHS just become a better, I guess, more well-oiled machine that, stop such problems? So, a crisis such as COVID has actually almost helped the crisis that was there before in some ways.
It's going to be very interesting to watch. And we've seen, I watch the daily briefings from Number 10, and I see Chief Medical Officer Chris Whitty talk about, we really want to avoid the situation where people are not going to hospital with things that they really should go to hospital with. If you're having a stroke, then the sooner you get there, the better. If you're having a heart attack, chest pain, the sooner you get there, the better. If people, on the other hand, at the other end of that scale of acuity, if they've learned that they can manage the more minor illnesses through different routes, whether it's self-care at home, whether it's accessing 111, whether it's going online, but not going automatically to A&E, trying to automatically go to the GP. If that is the case, then that might be a good thing, as long as they're not withholding those things that really need to be seen and need urgent care. The other factor is that people have found what they can handle remotely, and I mean patients and doctors and clinicians have found that they can handle consultations remotely, whether it's in primary care, or whether it's doing an outpatient clinic in secondary care, or whether it's a nurse practitioner or whatever it is. They've found that they've probably been surprised with what they can handle virtually and how safe that is. I remember not so long ago, not so many years ago, we were very reticent about doing telephone consultations because medico-legally the situation was, are you putting yourself in a position where you can make a diagnosis and treat that patient? And now, of course, we're very used to doing teleconsultations, advising people about, let's say, their asthma inhalers on the basis of peak flow readings that they've taken and relayed to you either over the phone or via an email or whatever. Teleconsultation is pretty much commonplace now. So it's going to be really interesting to see those things mixed up with more intelligent usage of the NHS, more intelligent usage of the technology to make the whole thing run a lot more smoothly.
I think actually a point you made there would be quite interesting, because we're talking about how the NHS is the ones that need to adopt the technology and the clinicians are the ones that need to really embrace it. But there's some ways as well. There's an argument for if the public adopt the new ways of working. So I mean, one company that I've seen online that's had some rapid growth, eConsult. So they provide video platforms for doctors, I think, and they've gone from 300 consultations per month to now processing 3,000 consultations an hour, which is absolutely crazy growth. But again, post-COVID, we have an aging population. It might be the case where the public, a lot of them do like going to their GP surgeries and having that FaceTime with a doctor. And, although they maybe can use, technology and videos, they actually still prefer to go. So there could be a bit of a pushback maybe from the public after, where the NHS is saying, let's bring all this technology in. The clinicians are really happy to use it, but there could be a certain percentage. So I think it'll be quite interesting, spanning several months, how if there's any polling done maybe of the public and how they coped with the technology during this crisis.
And I think, as you say, there's the patient getting used to that way of consulting as well as the doctor getting used to it, and the sort of reinforcement or the establishment of trust in that relationship. And you see that in the consulting room, where if you're making, let's say you're making a diagnosis on a skin problem, and in dermatology, so much of the diagnosis is on the history from the patient and looking at the lesion or the rash or whatever, and not so much touch. You don't have to touch. You look and not. But if you don't touch the patient, if the patient doesn't feel that that you've touched them, they don't somehow feel they've been examined, which is kind of, weird but understandable. Teledermatology, as you say, a lot of those startups, there's a lot of teledermatology startups, so that underscores that point. And so patients probably have to get used to the idea that they actually don't need to be physically touched to be examined, physical face-to-face. There's a lot that we can do by looking at things, looking at photos, looking at videos, conducting video consultations just as safely as in the old world. But there's that trust there. They need to feel that they're not being shortchanged. The doctor needs to feel that they're not medico-legally putting themselves in a precarious, vulnerable situation by having a virtual consultation. Needs to be safety netted so that, if things aren't improving, then the long stop is always having a face-to-face. But that's going to be really interesting to watch as we get through this. My gut feel is that we won't snap back to exactly where we were.
Yeah, I think in some ways, I think it'll be harder to snap back to where we were than to progress forward in some ways. It'd be we'd almost have to be so anti getting back to it. Yeah. So for health technology companies, then, from your own experiences, from a medical profession, and also you've got quite a bit of commercial experience as well. What do you think health technology companies, CEOs, founders, management, senior management of these health technology companies, what can they do during COVID and then post-COVID to ensure that their technology is still being embraced? What maybe some tips, I guess, that you think would sit well with the NHS to continue their growth?
Yeah, no, it's a great question. And the people process technology thing is really important. And it's really like a 3-input AND gate. In other words, all of those inputs have to be set to 1. They have to be positive to get a positive outcome. If any one isn't right, then it's not going to work. And frequently it can end up in a disaster. So, if you take the example of PACS, or Picture Archive and Communication Systems, digital x-rays, PACS, the technology was there and pretty well trusted. The process and the people, the radiologists and other departments that use x-rays, they were ready to change. And lo and behold, the world just moved from silver halide films and a very clunky way of dealing with that process overnight in this sort of mid 2000s to digital x-rays across the whole of England and the UK. So I would say bear that in mind, because it's really good and interesting, and we all get turned on about talking about technology, but technology is not the main point. And you have to go back to what's the problem you're trying to solve and who's going to pay for it. And so many of the digital health startups that I see, people really flounder when you ask them those really simple questions. And I learned that through the .com era, which is 20 years ago now, to ask that question: tell me how it makes money, who are you selling it to, why are they paying for it, what's the benefit they're deriving from it? Because it's tempting to think that if you're doing stuff in health, then and a lot of things in health that are mother of apple pie, they're a great idea if you can make them happen, but they have to be driven by some flow of money, because otherwise it won't be adopted. So going back to what's the problem you're trying to solve, what's the benefit to the end user? Is the end user different from the consumer in terms of the customer, rather, in terms of who's paying for the service, why are they paying for the service, and what benefit? Because otherwise it's just an interesting piece of technology that won't be adopted.
Yeah, that's very true. Yeah, that's very true. And I think that advice goes not just for health techs, but any company that's wanting to start a new business, isn't it, really? That's the staples of what an investor would ask and look for. One point about technology companies, providing so much support to the NHS is, could there be a degree of reliance in the future on the NHS, on these technology companies? The NHS obviously got NHS Digital and they've got a huge amount of applications internally, but could there be a point where the NHS is so reliant on private organisations that it kind of shifts? Obviously there's the whole argument and some of the from a political standpoint of wanting to privatise parts of the NHS, etc. But there could be so much input and reliance on it, couldn't there? So that's another point, I guess, to consider in the NHS to watch out for.
Yeah, and it's worse if there is a almost monopoly supplier. Obviously, it's good for the NHS. Back to the sort of plurality of providers thing that we were talking about, within rules and standards. Then, if we've got more than one provider, certainly, and several providers, then there's some stability there, and the interoperability helps. If one provider can be swapped out for another relatively easily, then that also helps. Let's not forget that the NHS right from the very beginning has kind of outsourced large parts of its functions, and again, general practice is a great example of that. General practitioners are not generally employed by the NHS. Increasingly, they are employed by practices, but those practices are individual businesses in themselves, and they subcontract to the NHS. The NHS in general practice owns very little of the property that's owned by the GPs, the practices, and the rent is paid to them. So the NHS benefits from that because it's not owning and maintaining and those properties and so on. So right from the beginning, we've had that kind of outsourcing. It's not new, and I think that's one of the strengths of the NHS. Enormous strengths that makes it so reliable for us and has enabled it to provide such great service over the years. Now, if that expands in the future, then I think that's going to be great. But it's not. I don't think it is what most people mean or fear when they use the word privatization. I think what they fear most is having to pay and not being able to pay, and therefore not being able to get the service they need.
Yeah, true. I that's a good point, because there's a mixture of health companies that are work with the NHS, and so you get your service through the NHS, and that technology company is helping. Say if you're in A&E or in the hospital, you've got technologies that are helping the patient flow and the management and monitoring symptoms, and then there's also a number of other technology companies, health technology companies, that are more for the private market, or they're for direct to consumer, and that does cost. But I mean, that then is just the choice of the consumer, isn't it? It's their choice, much like private health is as well. So I think it's quite nice that you've got that split. You've got health technology companies that aren't just going after the B2C market, they're looking to integrate the NHS, but also you've got some fantastic companies that are providing services direct to the consumer, that there is a cost, but the cost is it's looking after your health, which you can't really put a cost on in some ways, can you? So
yeah, it's a difficult business model, because in commercial terms, NHS is a very high volume, low margin business. It's run on very thin margins. So if a private provider comes in and thinks that they can, by virtue of increased efficiencies, within the NHS reimbursement envelope, if they can make a profit, then there's a history of organisations being disappointed in that. If you're providing a service outside of the NHS, as you say, direct to the consumer, that they're paying for, and they see value in that, and they're willing to pay, whether it's out of their own pocket or if they've got some kind of insurance underpinning it or some kind of reimbursement underpinning it, then that is a value add, and people will pay for, let's say, convenience or the being seen at certain times and so on, or a different kind of service. Then that's a different model.
Well, that's a good point, because there could almost be, hopefully not, but there almost could be an argument for a risk of health technology firms maybe going after the greater margin, and maybe like in the US, obviously, where it is all privatized, the insurance companies are paying big bucks to give to help reduce the need to pay out for policies, etc. So there could be an issue that the health tech firms go after the kind of the private markets and grow out there, because they could make more money. But in some ways, a lot of the founders that I spoke to, they've got such a good desire, and that's the beauty of the healthcare space. I think they've got a desire to really help the patient at the end of the day, and that's what they're setting out to do, really. So but I think globally it'll be interesting to see how the health technology market kind of develops, and how companies out in the US or other places, health technology companies that are helping emerging markets, just how they all operate really, because there's so many in Europe and overseas that aren't in the UK yet, and are offering some really great things.
Mm.
Yeah, and that actually leads on to my next point. So away from maybe the NHS, but more into the drug discovery space, there's a high number of health technology firms, helping fight the COVID-19 and helping develop the vaccine. What do you think, going forwards in the future, the drug discovery space will look like? Do you think the normal wait time of 10 years for a drug to be developed and put to market, hopefully you could see that come down. But I guess pharma companies are going to collaborate more and more with these emerging small tech companies that are specializing in machine learning techniques and deep learning. I think that's another really exciting kind of tangent and market that's going to emerge from this as well.
Mm. Yeah, I mean, there are a number of things happening at the moment that don't normally happen. One of them is a focus on coronavirus and trying to produce a vaccine for this particular virus. Another factor is that companies are therefore collaborating. So we've seen GSK collaborating with Sanofi, where normally they compete. And maybe that degree of collaboration we can't expect to survive when things get back to normal or more normal. And maybe there's government will and government help to get these things off the ground quickly, because it's a problem for the whole of society and the whole of the world, every single patient on the planet potentially. So maybe that is providing an impetus. Again, really difficult to predict, and the future is notoriously difficult to predict. But one would hope that some of these things, some of those barriers that have been broken down, that we found that we can do things in a slightly different way. Maybe there are collaborations between companies that can be crafted, which will be, wouldn't have been created if we hadn't had this crisis. Maybe there's a clarity about the priorities for health provision, which didn't exist before. And so companies can be more focused in terms of which particular areas they go after in terms of their drug development process. Maybe the application of technology to that drug development process has been accelerated the same way we've been talking about in actually providing healthcare. And when I was working with an AI group and talking to different pharmaceutical companies, talking to the pathologists, the histopathologists who are looking at slides and seeing whether that candidate molecule has actually hit that target and could become a useful drug. You talk to some pathologists in one company and they would say, they're fearful for their job, that they would be digitized out and replaced by a bot, an AI bot. Another company would say, the pathologist would say, look, we've just got too much work. We're going into work with this tsunami of slides and things to look at. So bring it on. If we can use the AI to triage cases and to make our life to add. So not replacing the human with a robot, but taking the robot out of the human, as it were, getting the bot to do some of that pedestrian stuff like counting individual cells per high power field, which is very laborious, very boring, and humans tire at doing that stuff, whereas a computer will just churn that stuff out. So maybe those barriers have also been pushed at to see how can technology be deployed to make things more efficient in that space as well.
Mm-hmm. I think it'd be really interesting to see. I'm sure there'll be some really new interesting technologies come out of this in some ways, with so many great minds and companies collaborating and thrown together and working together. There's going to definitely be byproducts of it that hopefully will be of great help. And, maybe from the mergers and acquisition space as well, there could be, I'm sure the big pharma companies are interested in some of these small biotechs and tech companies popping up that can help, develop and ramp up their drug discovery timelines. Good. I think the last point to just talk about, just to really illustrate kind of what we're speaking about, is your report we talked about from Fujitsu, just showing that because it was written back in 2013, and obviously we'll go into it now. Just how long this technology has been around for in some ways, and how it just now is coming to really being implemented and looked at several years later. So if you were to give an introduction to what that report was on and how you structured it.
Yeah, we were looking at how someone with a chronic disease like diabetes, for instance, really ideally they'd like the disease to disappear. That's probably too much to ask, but along the way towards that, there is a point where it gets pushed into the background of their life and it's not so intrusive, and it doesn't intrude on their day-to-day activities. So I was working, as you say, at Fujitsu, and I was working with a colleague who at the time was overweight, diabetic, very, very experienced in having diabetes. Also long-term, this is someone in their 50s, so been in the IT industry for a long time and very technically minded, and also very experienced in NHS IT and lived through the national program. So had all the sort of perspectives necessary to say, right, what could be possible? How could we apply technology to really change processes, and really with the end point of it's to do with patient-centric benefits. So how would this benefit the diabetic? And it's a structured program of change that achieves those benefits, and that change is underpinned by the IT. So we took a typical day for this diabetic, from waking up and having to do the finger prick test. Could it be a tattoo under the skin, which you could just point your phone at and it would read the blood glucose from reagents that were reusable in under the skin, right through his day, going to the gym, his activity communicated wirelessly to his phone, and then up to a medical record or his wellness record. The virtual consultations that we were talking about, does he need to take time off work to drive to the clinic, to park in the car park, wait in the waiting room to get about 10 minutes with a diabetologist, and then go back to work and so on? Or could that be done virtually? The communication of results and long-term trends could be communicated virtually. You could have virtual consultations. So we worked that up into a story of Bill's day. We called him Bill. His name wasn't Bill in reality, but we drew a picture of how that day could be different. And as you say, it's remarkable how some of the things have come to fruition, some of them haven't. And again, I would rehearse the theme that probably it's not the technology which has been the constraining factors there. It's around changing expectations, changing how we behave on both sides, patients and doctors.
Yeah, no, it was really interesting to read through, actually. And what was quite amazing to see is your point of how to effectively make your diabetes disappear. It sounds crazy, but when you actually read through the diary of Bill, it can be done, just because his life is made so much more easier. So if I can, I think I'll drop the link to that maybe in the comments when we post this. I think it'd be really interesting for people to read through. And I think, just to emphasize, that it is amazing that was back in 2013, where the landscape was so different, and it has taken time for this technology to be maybe developed but also adopted, because there was some of that technology was about back in 2013. But but I think summing up, I think, as we said at the start, one of the hardest barriers to getting technology out there is in some ways, on the way to being not solved, but alleviated, the soft skills part, the people's aversion to new technology, new ways of doing things. I think, hopefully post COVID, as tragic as it is, it has shown, public and the NHS and any other healthcare provider out there globally, that how technology can really help, both from a cost perspective, from a patient life perspective, to just improving ways of working, and also on the drug discovery element. Hopefully 4, 5, 6 years down the line, we can see new diseases being treated in different ways, and diseases that at the moment maybe have got are very hard to treat or can't be treated, they're on their way maybe to increased having the drugs to treat that. So I think there's a lot going on there. So I think that's really good. I think that really thanks for your contribution. I think it'd be a really interesting conversation.
It's a pleasure. Yeah, thanks for the invitation. Yeah, I think that the final thought would be around just always ask that question. What's the problem you're trying to solve? What's the benefit? And crucially, who's going to pay for the service? So digital health companies that are, at the beginning of their journey, always got to, whichever stage of the journey, but certainly the beginning, got to constantly keep that in mind.
Yeah, definitely. And I think just on another point, you're open for some advisory positions in the tech space. Yeah. So I think
absolutely.
anyone watching this that is interested, get in touch. I'll link Lester in the post so people can see your profile. But yeah, I think, with your experience, you're a great help, and you've been a great help with some of our, companies we've worked with in the past, helping them know and navigate, the beast of the NHS and just general commercial and medical advice. So yeah, definitely keep that in mind. But yeah, again, thank you for that, all that discussion and insight, and we'll conclude it there.
That's brilliant. Thanks.
Thanks a lot.